So greetings from Ohio to everyone who is joining us here. I'm so glad we could gather together as a community today virtually. So I'm going to talk to you about my work on TGFbeta, transforming growth factor beta, and how it seemed to drive smooth muscle disease in cystic fibrosis. So smooth muscle and cystic fibrosis, we do tend to think about the epithelium in CF. We think about the skin, the nasal epithelium, the respiratory epithelium, the intestinal epithelium, and that's for good reason. A lot of the pathology is derived in the fact that the epithelium has lost CFTR function. But there is evidence the smooth muscle in cystic fibrosis is also not doing its job quite right. Now, we all have smooth muscle in our airways. It lines our airways, rings the airways from the trachea down to some of our smaller bronchioles. And when it constricts or squeezes, we have bronchoconstriction. So first, let's talk about smooth muscle in CF. So airway hyperreactivity is just easily triggered bronchospasm. This can be due to changes in weather, changes in temperature. It can be due to a virus. It can be due to an inhaled chemical such as methacholine, which is a classic bronchoconstrictor. And what I'm showing here is that airway hyperreactivity is found in over half of people with CF. I'm showing a figure here from a 1988 paper that looked at the methacholine response in people with CF and people with asthma. Now, methacholine classically causes bronchoconstriction severely in people with asthma, and you can see that the people here under the gray band are those with asthma who respond with excessive bronchoconstriction to methacholine. However, over half of CF patients also have that excessive constriction response. And this is important, and I'll talk more about that in a minute. As was mentioned, earlier in the conference, about a third of people in the CF registry have a diagnosis as well of asthma, and that is a bit unclear as to whether this is truly like asthma that might be found in a non-CF population. Perhaps some people with CF have allergic asthma, but some people with CF might have other phenotypes of easily triggered bronchospasm that doesn't quite fit in asthma and doesn't quite respond to asthma therapies like we might expect. So we also know that children with cystic fibrosis have increased airway smooth muscle burden on endobronchial biopsies. So when biopsies are taken of the airways, children with CF have excessive amounts of smooth muscle around the airways. Now, it's been thought that perhaps these changes could be due to just the excessive amount of inflammation and infection that is present in the lungs of people with CF. But then recently, from Dr. Stoltz's lab in Iowa, newborn pigs with cystic fibrosis were shown to, from the get-go, prior to infection or inflammation, already have airway obstruction and airway smooth muscle constrictions. The smooth muscle were already constricted. Furthermore, he demonstrated that these airway smooth muscle cells have altered calcium reuptake. And calcium is kind of, intracellular calcium is the signal for smooth muscle to constrict. So if there's issues with calcium reuptake, the smooth muscle stays constricted inappropriately. So, okay, so smooth muscle appears to be altered in CF, but does this really matter clinically? I think that it does, and I think we have several good data points for this. So first of all, we know that for many children and adults with CF, bronchoconstriction leads to intolerance of evidence-based medications. Two that spring to mind as a clinician are Lumacaftor, Ivacaftor. This is the ingredients in our combi, and there were many people who were unable to tolerate this because it led to chest tightness, bronchoconstriction, and cough. Furthermore, 7% hypertonic saline, there's a good number of people who can't tolerate that due to the fact that it causes bronchoconstriction. So we know that bronchoconstriction leads some people to stop certain medications. We also know that bronchoconstriction probably matters in people's response to viruses, including coronavirus, and that people with excessive bronchoconstriction probably have a poorer outcome during viral illnesses. We also know from that 1988 study I mentioned previously that people who have that airway hyperresponsiveness, that vigorous constriction, they also have faster lung function decline and more exacerbations. So it actually seems to predict a worse outcome in people with CF if you have both CF and easily constricted airways. So why is this a problem for some people with CF, but not others? And like so many things, I always think of the schematic. And this is about the phenotype of lung disease and cystic fibrosis. So of course, the CFTR genotype is one important contributing factor to the ultimate phenotype. But there's also stochastic or random events, environmental factors, and genetic modifiers. And that's what I'll be mentioning here today. So it's been estimated that up to 50% of the variability in CF lung disease phenotype is due to non-CFTR genes. So the other genes that you have besides the CFTR gene. And one of the best studied modifiers is transforming growth factor beta 1. So this is a growth factor naturally found throughout the body, including in the lungs. And we know from a study by Mitch Drum that it is a strong genetic modifier in cystic fibrosis. So this figures from Dr. Drum's paper. This was looking at a group of people with delta F508 mutations, and they were categorized into people who had a more severe lung disease phenotype in these dark blue bars, and then more mild phenotypes. And what they found is that two high-producing TGF-beta polymorphisms, one in the promoter and one in codon 10, those were highly associated with individuals who had a more severe phenotype. So basically, if you naturally produce more TGF-beta, you had worse lung disease if you also had CF. TGF-beta has also been looked at as a biomarker of worse outcomes by Dr. Tom Harris in Birmingham. And he showed that higher levels of TGF-beta in the lungs, which may be due to polymorphisms or may be due to other factors, were associated with more exacerbations and higher rate of Pseudomonas infections and poor outcomes after treatment with IV antibiotics. So this led us to ask if TGF-beta might be linked to airway smooth muscle dysfunction in children with cystic fibrosis. So what I'm showing here is data from a small study I did with a pediatric pulmonary fellow in Cincinnati Children's, Dr. Nancy Lin, and we looked at some banked BAL or bronchoalveolar lavage specimens obtained from children at our center. So we looked at BAL specimens from 40 children, all about 12 years old, and they had very normal lung function at baseline, just about 103%. This was not an especially sick population. And we looked at the TGF-beta levels and some clinical outcomes in those children. We also looked at a number of other cytokines that I'm not getting into today, but there was nothing especially revealing in those studies either. So we looked at the FEV1% change in the next year, and also how the children responded to a bronchodilator, specifically albuterol. So these children had pulmonary function testing done. They were then treated with albuterol, and pulmonary function testing was repeated. This is a proxy for airway smooth muscle dysfunction, because if treatment with albuterol significantly relaxes your smooth muscle, that implies that your smooth muscle was at baseline relatively constricted. So we first saw that if children had any active TGF-beta present in their BAL, they were more likely to have a worse FEV1% change. You can see, however, that all of our children did fairly well over the next year, and actually they did not lose lung function, but still those with any active TGF-beta had a worse FEV1% change in the next year. We also found a trend towards total TGF-beta levels being linked to bronchodilator response. So these are individuals who did not have a bronchodilator response, and these individuals who did have a bronchodilator response. Again, this is a small study, but this led us to think about the role that TGF-beta might play in abnormal airway smooth muscle function. So we hypothesized that TGF-beta drives CF-relevant lung remodeling and disease, including exacerbation of underlying airway smooth muscle defects in cystic fibrosis. It kind of unmasks an underlying defect. So to really get at what TGF-beta is doing in the CF lung, we turned to a mouse model of cystic fibrosis. So here I'm going to show data from the delta F508 homozygous mouse, and they are gut corrected, meaning they actually do not develop gut pathology in this model. Now, I have an asterisk here to remind me to tell you that these mice, unlike other models and unlike people, do not spontaneously develop CF lung disease. So at baseline, the lungs of these mice look pretty normal. So we took these mice and their littermate non-CF controls, and then we administered either PBS as a control through the trachea, or we administered an adenoviral vector carrying a constitutively active TGF-beta transgene. So this is a way for us to overexpress TGF-beta in the lungs of these mice at a fairly consistent and titratable time level. And we chose this dosage because it was a physiologically relevant dosage. We also had an empty vector control because we've talked a lot about inflammation in this conference. The adenoviral vector itself in sufficient concentration can cause inflammation and other defects. I won't go into the data here, but this empty vector at this dosage did not cause any significant changes in the lungs. And we would treat these animals at day 0 and study them at day 7. So first I'm going to show you the lungs of these mice. So these are slices through the lungs of these mice with a trichrome stain. In the trichrome stain, you have connective tissue or fibrotic tissue in blue, as you can see here. Nuclei are in dark red and the cytoplasm is in pink. Here we have empty vector non-CF and CF mice, and TGF-beta treated non-CF and CF mice. And what you can see, this is an airway here and an accompanying vessel. We can see in the mice exposed to TGF-beta, these are inflammatory cells around the airway, around the blood vessel. We see thickening of the epithelium here. Although I'm not showing it on this slide, we also have more goblet cells producing more mucus, but those are similar in both the non-CF and the CF mice. So just looking at the lungs, we did see inflammation, but they looked very similar. We did not see fibrosis in this model. We also saw mucus plugging. So we saw, again, both in non-CF and CF mice who had a bit of TGF-beta in their lungs, we saw mucus plugs. Here we have a mucus plug in a proximal and distal airway here, and that was accompanied by increased numbers of goblet cells. So, so far the data looked pretty similar. It seemed like the CF and the non-CF lungs were reacting pretty similarly to TGF-beta. But then we decided to look at lung function. So here we're looking at lung mechanics obtained on a Flexivent machine. So we don't get pulmonary function tests in mice quite the same as we do in humans. Typically, you can't really ask a mouse to take a deep breath and blow as hard as they can. So we have a lung mechanics that we can obtain basically by putting the mice on a ventilator and measuring different pathologies. And what we're looking at here is pulmonary resistance. This can be thought of as a proxy to obstruction. So what we can see is in non-CF mice who are exposed to TGF-beta, they do develop increased resistance, but CF mice develop much higher levels of pulmonary resistance than the non-CF mice do. So they are developing much greater lung disease functionally than the non-CF mice with this bit of TGF-beta. We decided to dig deeper and try to figure out why we have this differential response. So we decided to take a look at the signaling pathways that are being turned on downstream of TGF-beta. Now, the classic TGF-beta signaling pathway, the canonical pathway, is called SMAD, and this is typically thought of as one of the major ways that TGF-beta affects changes in gene expression and might drive lung remodeling or inflammation. And this is a Western blot looking at whole lung homogenates of both non-CF and CF mice, and you can see that TGF-beta exposure activates SMAD signaling in both sets of mice, pretty much to a similar level. So that did not look different. However, we did look at some non-canonical pathways, including the PI3 kinase pathway, which is a different pathway through which TGF-beta can affect changes in gene expression. And what we saw here, looking again at a whole lung homogenate, was that this signaling pathway was activated much more highly in the CF mice than it was in the non-CF mice. So this was one of our first hints that the CF lung is really responding on a cellular level differently than the non-CF lung. We also decided to look at cytokine production. And again, I'm just going to show you one of those cytokines here which caught our attention. So we did bronchoalveolar lavages in these mice and looked at the concentration of many cytokines in their lungs. And the one that stood out as different than the non-CF mice was IL-6. So IL-6 levels in the CF mice were much higher than in the non-CF mice. We furthermore found that the downstream signaling pathway, the STEP3 pathway that is activated by IL-6, was also more greatly activated in whole lung homogenates of CF mice than in non-CF mice. So CF mice have more PI3 kinase signaling, and they have more IL-6 production and IL-6 pathway activation than do their non-CF counterparts. So we also knew that PI3 kinase and IL-6, among their many functions, they also can drive smooth muscle hypertrophy and hypercontractility. So we wanted to look specifically at airway smooth muscle responses in the CF mice. So the first thing we did was we took, again, this is lung histology, and we stained it for alpha SMA to stain smooth muscle brown. You can see here we have airways in non-CF and CF control mice, and in non-CF and CF mice that are treated with TGF-beta. You have the brown, which is the smooth muscle encircling those airways. And we quantified this and corrected it to airway size. And what we found is that we had a trend toward an increase in the non-CF mice that did not reach significance, but we had a very significant increase in our CF mice treated with TGF-beta. So CF mice respond with more vigorous smooth muscle growth to TGF-beta. So we have more smooth muscle, but does it constrict more in CF mice? So the way we can get at this is by looking at airway hyperreactivity, and very similar to in people, we can do a methacholine dose response in mice. So here on the x-axis, we have increasing doses of methacholine, and then on the y-axis, we have the pulmonary resistance. And so a shift upward would be indicative of airway hyperreactivity as you reach higher doses of methacholine. Here I'm showing the control mice, the non-CF mice in black and the CF mice in red. And again, at baseline, so these are the control groups, CF mice don't have significant lung pathology, so they do not have airway hyperreactivity at baseline. However, when we treated these groups with TGF-beta, we did see that CF mice develop higher resistance at baseline, which I showed previously, as well as higher responses at every dose of methacholine than did the non-CF counterparts. So they did have increased airway hyperreactivity in response to TGF-beta. But perhaps this is simply due to the increased airway smooth muscle mass, which I just showed you on the previous slide. If there's more smooth muscle, it stands to reason that smooth muscle constriction might be more vigorous. So it might not be a difference in individual smooth muscle cells. So we decided to go back to our model and actually study these mice at an earlier time point. We decided to, in fact, look at them at day 3. And the reason we chose this was interesting, and I'm just going to summarize the data in interest of time here. But at day 3, these mice demonstrated no increase in IL-6. They did not have increase in airway smooth muscle burden and did not have an increase in baseline lung resistance. However, the CF mice did still have significant airway hyperresponsiveness at day 3, despite the fact that they did not have more smooth muscle around their airways at all. So we were interested in what signaling pathways might drive this enhanced airway hyperreactivity in CF mice. As I showed you previously, PI3 kinase signaling is extremely heightened in CF mice, so that was a reasonable place to start. So we turned to a pharmacologic PI3 kinase inhibitor, LY294002, and we basically repeated the experiment that I've showed you, did it at day 3, but this time we pre-treated a group of mice with this PI3 kinase inhibitor, and another group received vehicle. All mice were exposed to TGF-beta, and then we looked at their responses. So the critical outcome here was the airway hyperresponsiveness in mice. And what I'm showing you is, again, a methacholine dose response. We have methacholine on the x-axis, and then resistance on the y-axis shifts upward, indicate airway hyperreactivity. In black, we have non-CF mice treated with TGF-beta, and in red, we have CF mice treated with TGF-beta. These did not have PI3 kinase inhibitor. You can see that at high dose of methacholine, the CF mice did have increased airway hyperreactivity. So we treated these groups with the PI3 kinase inhibitor. In the non-CF mice, you can see that those treated with the inhibitor, their line did not change. Their response to methacholine did not change. However, in CF mice treated with inhibitor, we saw a reduction back to the non-CF levels, that we basically were able to eliminate development of the airway hyperresponsiveness by inhibiting PI3 kinase signaling. So finally, I just want to show you some preliminary data looking at how isolated CF airway epithelial cells and airway smooth muscle cells behave. And this is an area that we're starting to get into to really understand the tissue-specific responses to TGF-beta and how those responses combine in the lung to produce the lung disease that we see. So here we are looking at primary human lung cells, either airway smooth muscle cells or airway epithelial cells, treated with either control conditions or 10 nanograms per ml of TGF-beta. And I'm just going to show you some preliminary data here. So the first thing we noted from these studies that was interesting was that airway smooth muscle cells did not respond differently to TGF-beta in CF conditions. However, airway epithelial cells did. So here we're looking at CF and non-CF airway epithelial cells treated with TGF-beta, and we're looking at PI3 kinase signaling, which, if you'll recall, is enhanced in the CF mouse lung. And we did see enhanced PI3 kinase signaling in CF human cells treated with the TGF-beta, but only in epithelial cells. We did not see this pattern in smooth muscle cells. So it appears that the airway epithelial cells might be the source for the over-exuberant PI3 kinase signaling that we see. But what we did see in airway smooth muscle cells is that if we inhibited CFTR function with GlyH101 or INH172, two CFTR inhibitors, we saw a difference in calcium handling. So this is a FURA2 assay. This allows us to look at the concentration of intracellular calcium in these smooth muscle cells. And this is critical because, again, calcium is the signal to drive constriction. So what we saw in red, we have our two CF conditions. These are cells treated with CFTR inhibitors. Even at baseline, prior to stimulation, they have higher levels of intracellular calcium, implying higher levels of constriction. And when they're exposed to methacholine, which again drives constriction, we see that they reach higher peaks than do the control cells. So it appears that smooth muscle cells, and this fits with data from Dr. Stoltz's lab looking at the CF pig, CF airway smooth muscle cells are kind of primed to have an over-exuberant reaction to anything that causes bronchoconstriction. So to conclude, I've shown you that airway smooth muscle dysfunction is a real problem in cystic fibrosis. I think it's a real problem in exacerbations, in viral infections, and tolerating medications. CF mice do have abnormal TGF-beta responses. Specifically, they have increased levels of IL-6, they have heightened airway hyperreactivity, and they develop more airway smooth muscle mass than non-CF mice do. However, inhibiting PI3 kinase prior to TGF-beta exposure stops the development of this airway hyperreactivity. And this leads me to believe that the airway smooth muscle might be an important therapeutic target. Now, we do focus on the epithelium with our therapies and outcomes right now. You know, we look at sweat testing, NPD, nasal potential difference, and other epithelial indicators of CFTR function. However, I think that we should also think about the airway smooth muscle and how that might be affecting our patients and how different therapies might benefit or worsen airway smooth muscle function. Because right now, we don't have great therapies for airway smooth muscle dysfunction in CF. Again, it's not at all clear that typical asthma therapies, such as an inhaled corticosteroid, it's not at all clear that that would be beneficial for the majority of people with CF. In the future, I'm interested in investigating TGF-beta induced pathology in tissue-specific CFTR knockout mice. So we know that there is a complex interplay between the epithelium and the underlying smooth muscle. We know in the gut, for example, that you need to lose both epithelial and smooth muscle CFTR function before you have the full GI obstruction phenotype in these mice. So I'm interested in what we might see in the lung phenotype. We're also evaluating the effect of TGF-beta on co-cultures of primary human airway epithelial cells and airway smooth muscle cells to try to understand how those cell types communicate and work together to drive the lung disease that we see. My email address is up here if we don't have time to answer all questions, and I would like to thank the fantastic CFRI New Horizons grant that has supported this work. And also our lab group. Here we are pre-COVID. I look forward to the date that we'll all be able to gather together again. And thank you all for listening.